Welcome, everyone. We're about to take a deep dive into a field that has totally revolutionized surgery as we know it, ambulatory anesthesia. This isn't just about sending patients home early. It's a subspecialty built on incredible foresight, precision planning, and a really sophisticated understanding of pharmacology. And it's all driven by one single-minded goal: getting our patients safely through their procedure and back into the comfort of their own homes, all within a single day.
I wanted to start with this, in English, French, and Spanish, because it really gets to the heart of the matter. This is for every single one of you out there, on the front lines, navigating these complex cases in what are often incredibly fast-paced settings. So the goal for our time together is to create a really practical, comprehensive guide that respects that level of expertise. We're going to cover it all, from the basic principles right up to the tricky nuances of managing our most complex patients.
So here's our roadmap. We've laid this out to follow the entire patient journey. We'll kick things off with the foundations, the why behind all of this. Then, we'll walk step by step through the preoperative and intraoperative phases. After that, we'll get into the nitty-gritty of recovery and discharge protocols, and we'll wrap up by tackling the unique challenges posed by our geriatric and pediatric patients. Okay, let's start at the beginning. How did ambulatory surgery go from being a radical idea to the absolute standard of care? Well, it's a fascinating story of medical innovation, shifting mindsets, and a constant, relentless push to be better and more efficient.
So what is ambulatory surgery officially? This definition from the International Association for Ambulatory Surgery has a key phrase I really want to focus on: planned non-resident basis. And this is so important because it highlights the intention. The plan from the absolute beginning is for the patient to go home the same day. This isn't just a happy accident where an inpatient recovers faster than expected. No, this is a completely distinct, meticulously engineered pathway designed from the ground up for rapid recovery.
And believe it or not, this has been a long time coming. We're talking more than a century of progress. Way back at the turn of the 20th century, a surgeon in Scotland, Dr. James Nichol, was already performing thousands of pediatric outpatient procedures. His reasoning? He wanted to reduce the risk of hospital-acquired infections and lessen the financial burden on families. Sounds pretty modern, right? Then, fast forward to the 1970s. This was the real turning point. The first freestanding ambulatory surgery center opened up, and that completely changed the game, proving you didn't need a massive hospital to do elective surgery. Finally, in 1984, the formation of SAMBA solidified ambulatory anesthesia as the respected, evidence-driven specialty we know today. And what's the result of all that history? Well, it's this number right here, an absolutely staggering 80%. Just think about that. In the US, 4 out of every 5 elective surgeries are now done on an outpatient basis. This didn't happen overnight. It was really a perfect storm of 3 things coming together: minimally invasive surgical techniques, the invention of faster, cleaner anesthetic drugs, and a huge philosophical change that finally put to rest the old, outdated idea that every surgery requires an overnight stay.
Okay, that brings us to what is, in my opinion, the most important part of this whole process, the preoperative phase. I'm going to say something a little bold here. Success or failure in ambulatory anesthesia is decided before the patient ever sets foot in the operating room. It is all about the preparation.
Everything we do in the preoperative evaluation, every test we order, every question we ask, it all boils down to this one fundamental question. It's like a 3-dimensional puzzle. You have the surgical factors, the patient's medical condition, and something that's just as vital, their social situation and support system at home. If you can solve this puzzle correctly for every patient, you're setting everyone up for a safe, smooth, and successful day.
So let's start with the first piece of the puzzle, the procedure itself. What makes a surgery a good candidate for an outpatient setting? You might think it's about how long the surgery takes, but that's actually not the most important factor. The real key is the anticipated degree of surgical trauma. We're looking for procedures with a low risk of major blood loss, minimal fluid shifts, and postoperative care needs that can be easily managed at home. And as you can see from this table, the list of what's possible has just exploded over the years. We're now doing complex cases like lap hysterectomies and even partial knee replacements as outpatient procedures, things that would have been unthinkable just a decade or 2 ago.
All right, let's talk about the patient. The old way of thinking was full of these rigid cutoffs, right? Too old, BMI is too high. We've moved so far beyond that. The modern approach is all about one thing: the stability of their chronic conditions. Let me give you an example. A patient with severe but very stable, well-managed coronary artery disease could be a fantastic candidate. Meanwhile, another patient with what seems like mild asthma, but it's brittle and poorly controlled, that person is a much, much higher risk. It's not the label of the disease, it's the functional status. For something like obstructive sleep apnea, we use tools like the stop-bang score, not to automatically cancel the case, but to stratify their risk and make a smarter anesthetic plan, maybe favoring a regional technique to keep them off opioids and away from airway manipulation.
So this is what the preoperative assessment is really all about. It's not just a gatekeeping exercise to say yes or no. It has 4 crucial jobs. First, sure, it identifies the absolute red flags, the true contraindications, like a patient with end-stage disease, or, critically, someone who can't arrange for a responsible adult to take them home. Second, it's about proactive optimization. What can we do to get this patient in better shape before surgery? Third, it's our chance to be detectives, to uncover those critical clinical issues, a potential difficult airway, a family history of MH, and flag them for the OR team. And finally, and this is huge, it's about patient education. We use this time to manage expectations, give clear instructions, and make the patient an active and informed partner in their own care.
And speaking of patient preparation, let's talk about fasting. Oh my gosh, what a perfect example of how much things have changed for the better. We all remember the old dogma, right? NPO after midnight. It was simple, but it was awful for patients. It left them dehydrated, hungry, anxious, and even hypoglycemic. We now know, based on solid evidence, that for healthy patients, this rigid rule doesn't actually reduce aspiration risk. The modern guidelines, which allow clear liquids up to 2 hours before surgery, are so much more humane. They improve patient comfort, reduce thirst, and there's even good data to suggest they can lower the rates of postoperative nausea and vomiting. It's a win-win.
Okay, our patient is ready to go. They've been carefully selected, assessed, and prepped. So let's scrub in and head to the operating room. Now we're going to talk about how we craft the perfect anesthetic for the ambulatory setting, where our goals are a swift, high-quality recovery and, just as importantly, minimal side effects.
For general anesthesia, we're basically choosing between our intravenous and our inhaled agents. Propofol, as we all know, is the undisputed king of TIVA. It gives you that beautiful, smooth induction, and it has antiemetic properties, which is a huge plus for reducing POMV. On the other side, you have your modern volatile anesthetics. Sevoflurane and desflurane are fantastic for ambulatory surgery because of their low solubility. That means they wash in and, more importantly, wash out very quickly, leading to a fast, crisp emergence. Desflurane is the absolute speed champion, fastest on, fastest off, but it can be a bit irritating to the airway. Sevoflurane is a little slower, but it's much smoother and less pungent, making it a great choice, especially for mass conductions in kids.
But of course, general anesthesia is not the only option on the menu. In fact, regional anesthesia has been an absolute game changer for outpatient surgery. Let's be honest, GA offers a very predictable, controlled environment, but the benefits of regional are just undeniable. The big one, superior post-operative pain control. This means we can dramatically cut down on the amount of systemic opioids we use, which in turn means less nausea, less itching, less sedation, and less respiratory depression. Plus, patients can often maintain their own airway and breathing, and they can get up and moving so much faster. It's a cornerstone of any modern ERAS, or enhanced recovery after surgery protocol.
And we've got a whole arsenal of blocks we can use, from peripheral nerve blocks for arms and legs to neuroaxial techniques like spinals. Now, for peripheral blocks, we often use longer-acting agents like bupivacaine or ropivacaine to provide extended pain relief. But, and this is a critical point, for spinal anesthesia in the ambulatory setting, long-acting agents are a recipe for disaster. They lead to prolonged motor block and urinary retention, which are 2 of the biggest causes of delayed discharge. This is where the rediscovery of ultra-short-acting agents like 2-chloroprocaine has been so revolutionary. It gives you a fantastic surgical block for about an hour to 90 minutes, and then it's gone. Motor function returns quickly, bladder function returns quickly, and your patient can go home on time. It's a perfect match for outpatient surgery.
All right, the last stitch is in, the drapes are down, the patient is waking up, but our job is far from over. Now we enter the final phase, which is all about guiding the patient through a safe and efficient recovery. This isn't just a waiting game, it's an active, protocol-driven process.
In Phase 1 recovery, or the PACU, our gold standard for assessment is the modified Aldrich score. This gives us a simple, objective, 5-category report card to track a patient's progress. We're looking at their movement, their breathing, their blood pressure, and their level of consciousness. But I want to draw your attention to the last one, oxygenation. To get the full 2 points, a patient has to be maintaining an oxygen saturation of over 92% on room air. This is a non-negotiable safety milestone. It tells us that the major cardiorespiratory effects of the anesthetic have worn off. A patient generally needs to score a 9 or a 10 on this scale before they are considered stable enough to move to phase 2.
So, once they've graduated from the PACU, they move to phase 2 recovery. Here, we're looking at a different set of criteria. We're assessing their home readiness. Are their vital signs stable? Is their pain at a manageable level with pills they can actually take at home? Have they stopped vomiting? Can they get up and walk to the bathroom without getting dangerously dizzy? And finally, the last and most important checkpoint is their ride here. And I don't just mean a ride. We need a responsible adult escort. This person is a critical part of the safety net. They are agreeing to get the patient home, stay with them for 24 hours, and be the one to call for help if something goes wrong. No escort, no discharge. It's as simple as that.
So far, we've talked about a sort of standard adult patient. But we all know that's not always who's on our table. So now let's talk about how we adapt our approach for patients at the two extremes of age, our geriatric and pediatric populations. The core principles of safety and efficiency are the same, but the physiology and the risks are completely different.
When we're taking care of older adults, the number one thing to remember is that their chronological age is probably the least useful piece of information we have. What really matters is their physiological age, or their level of frailty. A simple tool like the clinical frailty scale can give us a much better sense of their perioperative risk than their date of birth ever could. We also have to remember to adjust our doses. Anesthetic requirements drop significantly with age. MAC for inhaled agents goes down about 6% for every decade over 40. The same goes for regional. Spinal doses often need to be cut by a third or even a half. But here's a really fascinating and positive finding. By getting these patients out of the hospital and back to their familiar environment quickly, ambulatory surgery might actually reduce the risk of postoperative delirium. That's a huge potential benefit.
And now for the other end of the age spectrum, kids. As we all know, children are not just little adults. They come with a whole unique set of challenges. A runny nose that you wouldn't even blink at in an adult can dramatically increase a child's risk of laryngospasm and bronchospasm. A history of being born prematurely, especially if they are under 60 weeks post-conceptual age, raises the terrifying specter of postoperative apnea. And then you have the behavioral issues, like emergence delirium, which is much more common in kids, and their incredibly high baseline risk for postoperative nausea and vomiting. A thorough preoperative screening is absolutely critical to identify these risk factors and have a plan in place to manage them safely in an outpatient setting.
So after all of this, what's the big picture? I think it's that modern ambulatory anesthesia isn't about taking shortcuts. It's the exact opposite. It's about perfecting every single step of the perioperative journey. It's a field that rests on 3 pillars: exhaustive preparation, individually tailored anesthetic techniques, and objective protocol-driven recovery. And it works. It has made surgery safer and more convenient for millions of people. But the story isn't over. We're constantly pushing the envelope, doing bigger surgeries on sicker patients. And that leaves us with the big question for the future of our specialty. How do we keep innovating and improving efficiency while we take on more and more complexity, without ever compromising on safety? That's the challenge ahead. Thank you so much for joining me today.